So thanks you once again. So my topic is to talk about surveillance in endoscopy. I'll try to answer these 4 questions in the next 15 minutes or so. Starting with the first one, do we need to screen IBD patients more intensely for colorectal cancer and dysplasia? And this is so far still the largest meta-analysis that we have from the literature in the last decade. As you see, summarizing more than 100 studies, more than 50,000 patients with UC, 1,700 patients with cancer. And in most of these studies also an evaluation of the duration of the disease was available. It is very clear from this meta-analysis that the incidence is increasing over time. You see here the time. And the general prevalence of cancer is around 3.7%, which means 3 cancer every 1,000 patients every year. So these meta-analyses dominate our work in endoscopy room in the last decades, because we know that in fact during time the incidence of colorectal cancer goes up to 18%, the cumulative risk after 30 years of disease. Indeed, in the last years, a number of new studies have been published. This is one of the most relevant to me because it's a single center experience with more than 30 years coming from St. Mark Hospital in London. More than 60 patients were followed. And you see clearly that the incidence of cancer in their series declines over time. And it's apart evident in their population that the risk was very much lower of that was estimated by the meta-analysis. Because talking about incidence of neoplasia, you see at 10 years was 1.5%, and at 40 years was 22.7%. And if you also only look to the poor colorectal cancer and not the combination of cancer and dysplasia, you see that at 40 years, the incidence is only 10.8%, so much lower than we knew. And you can also see that there is a difference progression for the evaluation of dysplasia up to the cancer. And you see here that patients with low-grade dysplasia have very slow progression to cancer, and the patient with high-grade dysplasia will develop very soon a cancer. So this changed completely our management of this patient. And this is probably the most relevant meta-analysis that you have to look for. So underline that the risk in the population-based cohort is completely different from the risk from the referral center and from the hospital-based cohort. This is a combination of 8 studies. One of these studies coming from Denmark comprised more than 50,000 patients with IBD. And they were followed for a mean follow-up of 7 to up to 24 years. So it's clear from this meta-analysis that for sure the standardized incident risk for cancer is increasing in this patient. And you see the risk is 2.4%. And this meta-analysis also tells us that there are some group of patients where the risk is even higher. For example, the male compared to female, the patient with younger than 40 years, and patient with more extensive colitis. Of interest also, including this meta-analysis, was this study from Sweden. In this study, indeed, in 3 different cohorts, there was not a clear decline of incidence of colorectal cancer, but more reassuring, there was a decline and was significant incidence of mortality for colorectal cancer. So it means that our policy of surveillance is effective in mortality. So to answer the first question, yes, we need to screen IBD patients more intensely to detect colorectal cancer and dysplasia. But then the next question is, has every IBD patient the same risk? We already gave you some data, and it's very clear by comparing the meta-analysis. There were many of referral center that made the experience in St. Mark at the population-based study from Copenhagen, that incidence was very different. This depends from the patient selection, but also because there are different risk factors that should be taken into account. And one risk factor was recognized already more than 20 years ago. This was from Sweden. And you see that it's clear that the extension of disease change in logarithmic way the risk for cancer, with very high risk in pancreatitis and not risk at all, I would say risk comparable to the background population in proctitis. There are, of course, other risks, which are the disease duration, the presence of primary sclerosing cholangitis, the young age at diagnosis, less than 30 or less than 40 years. Of course, the family history of colorectal cancer was completely ignored in the meta-analysis of Eden, and the presence of post-inflammatory polyps, because in that case surveillance is much more complicated, and more recently has been demonstrated that the active disease also at an histological level increase the risk of cancer. And these are, for example, the population from the St. Mark Hospital. You see that in patients with normal conic appearance, which means without inflammation, the risk is much lower. But in patients with post-inflammatory polyps and colon stricture, the risk of cancer is significantly higher. That's why in the consensus from the ECOS, or European Crohn's and Colitis Organization, we conclude that patients with IBD, both ulcerative colitis and Crohn's colitis, have an increased risk of developing colorectal cancer, which in the case of ulcerative colitis is variable based on the extent on duration, the presence of family history of colorectal cancer, the presence of primary sclerosing cholangitis, and what is reassuring that the risk to die from colorectal cancer has decreased in the last 35 years. So to answer this question, you should say that not IBD patients have the same risk, and then this is very important, we should be tailored the surveillance on the basis of different risk. That's to spare useless colonoscopy, to do better colonoscopy in patients that they do need. So what we can do to make a better stratification of this risk? First of all, starting with the screening colonoscopy very soon, which means 8 years after the onset of symptoms, not diagnosis. We know that sometimes there will be 6 to 12 months of delay of diagnosis. So we have to start at the beginning of symptoms, counting the 8 years. And then we have to stratify the patient based on the different risks. For sure, there are patients with high risk, and these are the patients with presence of stricture or dysplasia in the previous 5 years, the patient with the PSC, the patient with extensive colitis with active disease, the patient with family history of colorectal cancer younger than 50 years. These patients need a surveillance colonoscopy every year. Then there is an intermediate risk factor group. Those are the patients with extensive colitis with only mild or moderate activity, patient with post-inflammatory polyps, as I said, and patient with a family history of colorectal cancer, I would say also adenoma in first-degree relatives at 50 years and above. And there are also patients with very low risk. The risk is comparable to the general population, and patients with neither intermediate nor high risk factor. In general, patients with left-side colitis, patients with Crohn's colitis with less than 50% of a colon extension, and patients with no inflammation during the follow-up. These patients need a surveillance colonoscopy every 5 years, no more. So the next question is now what we can do to detect in a better way the presence of dysplasia that we know is the precursor of colorectal cancer, or to identify colorectal cancer in a very first stage. As you may remember, the standard recommendation was to have to do an endoscopy without inflammation or with just mild inflammation and perform random biopsy, so 4 biopsy in each quadrant every 10 centimeters plus biopsy on visible lesion. And with this protocol, the accuracy to detect neoplasia is around 90% if you perform 33 biopsy. And if you increase the number of biopsy, for sure you can increase the accuracy. But this is very time-consuming and troublesome for endoscopy of patient. And the general practice, these are published studies in different population of gastroenterology and endoscopists, you see the adherence to this biopsy protocol was very low. In most cases, less than 10 biopsies were taken. So for sure, a suboptimal evaluation of the risk of and the surveillance. And this is one classical example of how this sample biopsy can be completely useless. This is a large population from Netherlands, more than 1,000 colonoscopies, but in particular almost 500 colonoscopy in patients with long-standing IBD. And there were more than 11,000 random biopsy, which turned out to have only 0.2% of positive for neoplasia. In contrast, in around 500 targeted biopsies on suspicious lesion, the number of biopsy with neoplastic were 10-fold higher. So this underlines that random biopsy are completely useless. And then the next step was try to improve the targeting of the biopsy, for example, doing chromendoscopy. And this slide shows a comparison of the diagnostic yield of chromendoscopy done either with the methylene blue or indigo carmine compared to white light endoscopy. And in general, there was at least a 3-fold increase of diagnostic yield. You can see in this slide the meta-analysis of this study showing that in fact there was a 44% increase of detection of colorectal cancer of dysplasia, and this was reduced but was still at 20% diagnostic yield in the flat lesion. They were more difficult, of course, to evaluate. And some years ago, this acronym has been given to the literature, which is easy to remind, is surface guideline given by the German group of Kieslich. So the rule is to strict to patient selection, so to evaluate the right patient at the right time, as I say, 8 years after the beginning of symptoms, just for the first screening, and then to unmask the mucosal surface. It means to make a good quality colonoscopy with accurate bowel prep, with complete removal of mucus and fluid, to reduce, if you need, peristaltic waves with spasmolytic agent, to have a full staining of the colon, so a pan-chromocolonoscopy. This can be done with dyes, so with the indigo or methylene blue, and this will allow you to evaluate the crypt architecture, so the so-called pit pattern you will see in a moment in the next slides, and at that moment making target biopsy on mucosal alteration, and especially in what are suspicious lesion. This is the classification of Kudo, then can give you a first look at the possible difference between the crypt architecture when it's normal and very similarly not neoplastic, or when it start to be the range and more bizarre, and this is should prompt you to talk about biopsy in that area. And this is a nice comparison of the accuracy of the first only endoscopic appearance, and secondly the pit pattern, which was done in a group in Leuven by bishops, and he compared the evaluation of the accuracy of chromendoscopy with dye with NBI, which is the digital way to make the chromendoscopy. In general, the accuracy was very good, but if you see the positive predictive value was increased with chromendoscopy compared to NBI. So far, chromendoscopy should be preferred to the digital way to make chromendoscopy. So to answer this question, we need advanced imaging in this patient because it helps us to discover more lesion and to make less biopsy. So this is less time consuming for both endoscopists and pathologists. And that's the reason why the echo conclude that pancolonic methylene blue or indigo carmine chromendoscopy is the standard to make target biopsy, and only if there is not appropriate expertise for chromendoscopy, you may do random biopsy 4 every 10 centimeters, but you have to keep in mind that for sure this is inferior to chrome endoscopy to detection of neoplastic lesion. And you see there was a very large agreement with that, and that so far the new coming methods of imaging with narrowband imaging or autofluorescence has still so far not convincingly demonstrated to be superior, but time is changing, so probably in the future you see that already at that time there was not a complete agreement. Probably in good hands this technique can be even more helpful. The problem is the issue there is the cost and the diffusion and the expertise. Now we move to the final question, how we have to manage dysplasia in this patient. And the point is that to manage dysplasia you have to see it. And I will show you some example. For example, in this patient, still have an active disease, so probably was not a right moment to make the endoscopy. And at the first look, you just see the ulcer, you don't see anything else. But if you make the chrome endoscopy, you can recognize that there is an area which is completely different from the remaining mucosa, and so you have to make biopsy there to check if there is dysplasia. That was in this case. And going back to the recommendation of the echo, where dysplasia of any grade is found without an associated endoscopical visible lesion, you should do a repeat chrome endoscopy in experienced hands and try to evaluate if dysplasia is recognized with the visible lesion, if there is dysplasia also in the surrounding mucosa to assess for synchronous dysplasia. When a visible lesion is evaluated, that should be completely removed by an experienced endoscopist, irrespective of the grade of dysplasia and the localization relative to inflamed mucosa. This applies also to sporadic adenomas in context of colitis. That's why in this review, in other also consensus, the terminology of DALM and ALM, so adenome-like mass, has been completely abandoned because you simply have to do the same. If there is a suspicious lesion, you have dysplasia only in that lesion and not in the surrounding mucosa, you have to take away and then to evaluate by your pathologist. In the absence of dysplasia in the surrounding mucosa, you have to do a meticulous colonoscopy surveillance, of course, subsequently. And this is some cases. This is a 47-year patient with pancolitis. He has a 50 years duration of disease under mesalazine. He was well. There was a negative family history, and when he performed this endoscopy, in fact, there was something appearing here in the mucosa. There is something more relevant there, and when the high definition endoscope was applied, it was clear that there was a flat mass there, was around 2.5 millimeter, and then the chrome endoscopy was performed. This very precisely defined the surface of this mass. In this case, we decided to perform a mucosectomy, and the first stage was to make a clear demarcation just around the mass to have space enough, at least 2 or 3 millimeters, and then start to make the resection. This was a cap-assisted resection, and you see here was the final appearance of the position of the mass. Was confirmed a low-grade dysplasia. This is a more complicated case. Was a 55-year lady with left-side colitis in 20 years. He has also a number of comorbidity, and this large lateral splitting tumor was found in the rectum, and it was defined as low-grade dysplasia. To better define this tumor, blue methylene was used for chromo, and you see here was a very large mass. And we decided in this case to make a ESD because it was very large. It was 7 centimeters surface. It was a very complicated, long procedure that should be done only very expert hand. But you see at the end, this was the appearance, and this was the en bloc removal, and this turned out to be a villous adenoma with low-grade dysplasia, and there were no other areas of dysplasia in the surrounding mucosa. So what happens when we remove this lesion? This meta-analysis is very reassuring because this is the polyincidence of cancer after resection of polypoid dysplasia in patients with low tongue and UC. And you see the risk is very low. It's 5 cases every 1,000 years of follow-up. Of course, if you think about the recurrence of dysplasia, this is higher, is 10-fold more, so it's 65 cases every 1,000 years. But still, if the endoscopy can remove and block the lesion and there is no other area of dysplasia, this is the way to do. And there are, of course, definite indication for surgery. So when the lesion is unresectable, that should go to the surgery. If there is not lifting signs, you cannot remove the lesion. When there is an high-grade dysplasia without visible lesion, you have to go to the surgery. The same when the dysplasia is multifocal, or where there are other coincident factors like PSC, or the presence of multiple post-inflammatory polyps, we simply make impossible a correct evaluation, a correct surveillance in that patient. And to answer the final question, for sure, we can to manage the dysplasia, of course, in the right hand, the Asperis endoscopy. And these are my final slides. There are important take-home notes for dysplasia to take in consideration. You have to remove the resectable and the visible dysplasia. So this means that the endoscopy should evaluate this before. They have to take biopsy from all the surrounding mucosa in all the colon, have to tattoo the lesion because you have to come back in 3 months to check if the resection was complete. Of course, when the dysplasia is invisible, then you have to reevaluate the patient, first of all, to see if they're real dysplasia with an expert pathologist, and then if it's confirmed, then you have to go back with the better endoscopy you can, with high definition endoscope, with chrome endoscopy, take more biopsy than you can, and discuss the management of the patient. Other features should be taken into consideration, the duration of the disease, the age of the patient, but in most of the cases, probably the best conclusion is to go for the colectomy. So with this, I will finish. In my country, I say grazie per l'attenzione. Here I say spasibo za vrimarive. I hope to have the right pronounce, and thank you once again to be here in St. Petersburg.